Good afternoon, everyone, and welcome to CurePSP's Ask the Doctor, session number 7. Thanks everyone who's tuning in today via YouTube and Facebook Live. We hope that you're all staying safe, healthy, and enjoying this holiday season. My name is Joanna Teters, and I am the Community Outreach and Resource Manager with CurePSP, and I will also be the moderator of today's Ask the Doctor webinar. We are so pleased to have here with us Dr. Miriam Sklerov of University of North Carolina at Chapel Hill. Shortly, Dr. Sklerov will share with us a presentation on how telemedicine has impacted all of us in the age of COVID-19, and more specifically, our community of patients and caregivers with multiple system atrophy and related neurodegenerative disorders. Please note that this will be a recorded webinar, and the recording will be made available on our website and on our YouTube channel in the next few days. The link will be provided in a follow-up email. A quick overview for the platforms we're using today, Facebook Live and YouTube. Please type your questions into the chat box, the comment section of the platform you are using, and feel free to use the chat box to interact with each other, but please do not reveal personal medical info. It's very important. The questions that Dr. Sklerov will answer at the end of her presentation today during a Q&A were submitted prior to the webinar. However, if time allows, we may take a few minutes that were asked to answer questions that were asked live today. So please don't be shy and add any questions that you might have as Dr. Sklerov goes through her presentation in the chat box. Dr. Miriam Sklerov is a movement disorder specialist neurologist at the University of North Carolina School of Medicine. She completed medical school at New York Medical College and her neurology residency training at Columbia University Medical Center in New York City. She then completed an extended 3-year fellowship training in movement disorders at Columbia University. During her fellowship training, Dr. Sklerov obtained her master's in science and epidemiology from the Mailman School of Public Health at Columbia University through an NIH-sponsored T32 training grant. There, she developed a passion for caring for people with atypical Parkinsonism syndromes, particularly multiple system atrophy, progressive supranuclear palsy, and corticobasal syndrome during her training. She began to conduct research relating to these diagnoses, beginning with fluid biomarkers, genetics, and clinical trials during her time at Columbia University. Dr. Sklerov joined the UNC Neurology Movement Disorders team in August 2017 as an assistant professor. Since joining the group, she has created a clinical and research program dedicated to the care of patients with MSA, PSP, and CBD. In addition to participating in research efforts, both local and international, she has started a multidisciplinary clinic for atypical Parkinsonism syndromes. She also provides training for allied healthcare professionals, neurologists, and graduate students in these conditions. She is the director of the UNC CurePSP Center of Care and the UNC Autonomic Laboratory. Dr. Sklerov is dedicated to educating healthcare professionals, patients, and the general public about multiple system atrophy, progressive supranuclear palsy, and corticobasal syndrome, and promoting research for these conditions. And I have the pleasure of working with the UNC Chapel Hill team on a regular basis. At this time, I'd like to welcome Dr. Sklerov to today's webinar. Thank you so much for being here with us today.
Thank you, Joanna, and thank you everybody for joining us. Hopefully we'll be able to answer all the questions and maybe even inspire other questions that you didn't realize you had. So again, thanks for joining us, and I'm going to get started by talking a little bit about telehealth, which is a relatively new concept in the general public, but has been talked about in medicine for quite some time. So let's learn a little bit about this. So the objectives of my brief talk are going to be first to define telehealth. So we all know we're talking about the same set of things. And then I will talk a little bit about the different options for telehealth that are currently available. Now, just as a disclaimer here, of course, depending on where you are and where you get your care, there may be different options available. So maybe not everything that I present will be something that will be available in your area, but hopefully someday soon will be. And then I want to discuss the advantages and limitations of these telehealth options, but also how to optimize your telehealth visits. because, this is a very new concept for all of us, really. Okay, so telehealth is meant to heal at a distance. So the use of electronic information and telecommunications technologies to support long distance clinical health care, national health related education, and public health and health administration. So this is kind of the all-inclusive definition of telehealth. The WHO, World Health Organization has said that telehealth is meant to improve patient outcomes by increasing access to care and medical information. And this should be the goal of telemedicine and telehealth. So a little bit of history is that actually telemedicine, telehealth has been a concept that's been around for quite some time, for over a decade at least. And we've actually been using telehealth in neurology specifically for stroke management. And in stroke is a very interesting scenario because in stroke there are very strict codes of how a stroke code is managed. There are specific steps that have to happen and certain forms that have to be filled out in a certain way, and time from onset of symptoms to time of medication. Those things are very well defined. And there are many places even in the United States where there are no neurologists. There may not be a neurologist for 100 miles or more, or in multiple counties. So as a result, to be able to get people the medication that they need in time for a stroke, it made sense to be able to outsource or try to involve neurologists from who are not within 100 miles in the care of these patients. So we've been using telemedicine with video in particular for stroke management for quite some time. For cardiac services also, it's a little bit different. They don't really need the videos much, but we do send pictures or videos of cardiac monitoring strips like EKGs to be read by cardiologists who, again, there may be areas of the country where there's not a cardiologist who's available 24 hours a day to be able to diagnose heart attacks and things like that. And then, of course, in rural communities, this has been a little bit more not as widespread, but there has been some small grant funding efforts to deliver care remotely. So unfortunately, my images are not popping up here. I apologize. But the adoption of telemedicine has been slow for several reasons. Initially, the two kind of big reasons have been coverage. Insurance companies were not really keen on paying for medical visits that did not include in-person interaction and examination. And there was a lot of gray area about what would be covered, and a lot of times we weren't sure. And that could leave people with unwanted bills and unexpected bills, which of course nobody wants. And then there's the question of evidence. How good is telemedicine? Does it work as well as face-to-face visits? Can we get as much out of it as we can with seeing my doctor in person? And this has been really unknown for decades. And more research even now is still needed, but luckily we are getting a little bit more experience. So, excuse me. Of course, in the past year, since we've been in this pandemic, there are silver linings, for telemedicine in this pandemic. So, of course, the social environment, or the environment that has created this, is that we've needed social distancing. There has been stay-at-home orders. It's been not only not always safe to go to your doctor's office during the pandemic, but it's also been more difficult because there's maybe less transportation or less availability of appointments, things like that. So in this day and age, to promote health, to promote people's ability to actually be in touch with their doctors and get the healthcare that they need, insurance companies have rapidly accepted coverage and support for telehealth because they now, this has been kind of a major option, a major necessary option for people, with the goal, of course, of keeping everyone as much as possible out of the clinical spaces where they may be infecting each other or other people who may be more susceptible to COVID. So now this has been really wonderful for telemedicine, this environment that we can really push forward, and we've been able to provide telemedicine now for almost, in most places of the country. Whether or not this will be able to be continued after the pandemic, after the vaccine comes out and it's considered safer to go about our normal business, is yet to be seen. We are hoping that this will be the case, because we have found that there are lots of places in this country that even though people have been forever traveling for appointments if they need to, there are people who are traveling 100 or more miles to get to an appointment, especially to see specialists. And several states in our country right now are so underserved that people may be traveling across state lines to see their doctor, which of course is very hard to sustain, particularly when we're talking about MSA, PSP, CBD, where mobility is limited, and you may need a significant amount of help to get to your appointments. So now I want to talk a little bit about the different forms of telehealth. And this is particularly during COVID-19, because obviously this is an ever-evolving area. We may come up with even more different forms of telemedicine moving forward. So the first is that I'm going to mention, I won't talk too much about this, is called an e-consult. An e-consult is specifically between doctors or between medical providers. And what it is basically an email back and forth, a consultation. So the consultant in an e-consult never actually sees the patient or talks to the patient or lays hands on the patient. This is a form of consultation that happens when the referring doctor wants advice, usually on something specific, a specific question, but they want to handle the care themselves directly. And that could be for a multitude of reasons. Sometimes it is the provider preference, but sometimes it can also be the patient preference. Sometimes an e-consult, the advice that's given by the consultant is, well, actually, I need to see this patient. I really can't answer this question by email. But the hope here is to, try to save a visit for the patient. Then we have e-visits, and e-visits are actually something that's going to sound very familiar to you, even before the pandemic. This is a visit in which there will be an electronic message. So a lot of people who have MyChart or another electronic messaging system that they use with their doctors have been using this probably for some time now. This is where the patient will have a question specific to their care. This is for established patients. So someone who already has seen the doctor has an idea of what their story is and what is going on with them. And they message their doctor with a question, and the doctor responds. This is what we mean by e-visit. The advantages, of course, is that this is an email. This is pretty easy to do, or an e-message, a typed message is pretty easy to do. It doesn't require an appointment. It can be done, whenever you have spare time to write a message. It is asynchronous, meaning the doctor doesn't get the message immediately. They get it when they're looking at their messages. So it's not a great form of visit or for something that's more urgent or needs to be answered in a timely manner. But it is a great form of communication. Again, that doesn't require appointments, or timing is not of the essence. But in this visit, also the provider, the medical provider, never actually sees the patient. This is just kind of email almost. Then we have phone visits. Again, phone visits are almost exclusively for established doctor-patient relationships. So this will be a type of visit that you could do with your doctor who you've been seeing already. And again, phone visits are not a new concept. We've been having telephone calls between doctors and patients for a long time. But as you probably know, the motivation for a phone visit is that we can talk in real time about whatever is going on with the patient, and we can give advice over the phone. It does rely a lot on your own ability to, or the patient's ability to describe what is happening and what their problem is. Sometimes it's, there are certain things that can be very difficult to describe over the phone. Usually, in the past, these were usually unscheduled. This would be you call, and if the doctor's available, they will talk to you. Otherwise, they will call you back. Now we actually schedule these visits. They can be scheduled. Traditionally, before the pandemic, they did require that the patient and the provider are in the same state. That is no longer the case. I don't know how much longer they're going to allow that. That may change in the future, but currently we are still allowed to see patients or have telephone visits with patients who are not in the same state. Again, that is for billing purposes. And then we have video visits. So video visits are kind of the more new and exciting part of telemedicine that we think of that really has been propelled by this pandemic. Video visits can be for a new patient, meaning if you've never seen this doctor, it could be a new consultation. We can do those over video. Now, the caveat, of course, is that the examination is limited, right? We can't put our hands on you. We can't feel rigidity. We can't check your reflexes or sensation or strength. We can't check your blood pressure with our machines. So there are still limitations to this type of visit. It's not the same as an in-person visit. However, in many circumstances, it may be enough to be able to see someone on a video visit and do that limited examination to be able to start the process of treatment or start the process of a diagnostic workup. In most cases, when I see a patient with a new patient on a video visit, I will probably at least 50% of the time, I will say, you know what, before we go much further with this, I really do need to see you in person. But at least I'm able to give some initial recommendations to get the ball rolling so that they're not waiting for my next, my next available in-person appointment, which because of the pandemic, those are also limited, those slots. Okay. So now I want to talk a little bit about how do we get the most out of our care with this telehealth. And of course, there are lots of pros to being able to provide telehealth, and which I sort of mentioned before, but I'm kind of more explicitly saying them here. We can actually observe much of the, I said MSA here, but I also mean all of the Parkinsonisms. We can observe much of the important parts of the examination using video. So being a movement disorder specialist, a lot of what I do is looking at movements, which a lot of that I can see on video. And like I mentioned before, there are things we can't see on the video, but for the most part, we can usually see enough that we can get the process started to address concerns, to start a diagnostic workup if that needs to be done, to recommend treatments. And as I mentioned, there are certain parts of the examination that are just not able to be done on video that may need a follow-up in person for the next visit. So how do we make the most of our visit? So I want to say, thinking of these telehealth visits as a real doctor's appointment is important because right now, especially in the age of the pandemic, this really is our appointment. This is our visit with each other. So a lot of the same things that you think of when you go to see your doctor should also be done with a telehealth visit. So I always encourage people to have a family or friend available at the visit, someone. And much of this is because, especially with the video visits, operating the camera can be very difficult. it's one thing to hold you. A lot of times the visits are done on a cell phone. When you're holding the cell phone, it's hard for me to see your entire body. I'm mostly just seeing your face or very close up of a specific body part. But for me to be able to see your whole body, and which I need to do to be able to examine you, is very difficult to do when you're on your own. Even if you're setting up the camera or the phone, setting it on the table or something, a lot of times it needs to be adjusted. So it is much easier if you have someone there with you. But of course, always having someone there can also be another source of information for me, but also help you. When we're in a doctor's appointment, a doctor's visit, we had all these things we knew we wanted to talk about and mention, but when you're put on the spot, a lot of that stuff kind of doesn't get talked about. You forget about it, and then afterwards you say, oh shoot, I meant to say. So it's always helpful to have someone there to remind you, keep you on track. Another really important part of a telemedicine visit is to make sure that you have your medication list or even your bag of pills handy. I can't tell you how often I'm asking just to make sure that I know what the medications are that someone's taking, and they have to run and find their pills, which is fine, but it does eat up a little bit of time. So it's good to have that handy at the time of the visit. And then I always tell people, make sure that before the time of the visit, you've had time to sit down and write down all your questions, concerns, because just like a regular visit, when you're put on the spot, a lot of times those things fly out of your head. It's hard to remember those things in the moment if they're not written down and in front of you. Now, in terms of helping make the best quality of visit, especially for the video visits, for movement disorders, especially for MSA, PSP, and CBD, one of the main parts of the examination is watching you walk. And for me to really get a good idea of what I'm seeing when I watch you walk, I need you to be able to walk at least 10 or 15 feet away from the camera and then 10 or 15 feet back. So I always remind people to try to choose a room in their house or place in their house or around the house where there is an uninterrupted space of at least 15 feet where we can walk. And to set up the camera, hopefully somebody would be holding it, but if not, set up the camera at one end of the room in the long way. And then general tips: avoid having lighting behind you, because when there's bright light behind you, everything here goes dark. And mobile phones and tablets for the most part work best, especially if there's someone who can hold it for you during the examination. And then having a tech-savvy family or friend nearby when you're on your visit is also very helpful. It's so common to have technical difficulties or technical errors happening during the visit. Either the sound is off or the reception is patchy or something that can be really fixed with a quick fix for someone who's savvy with technology. And then, of course, have paper and pen handy, partly to take notes, to remember what we talked about, but also a lot of my examinations, I sometimes will ask people to write or do spirals so I can see how their penmanship looks, or how, if I'm looking for a tremor, for example, how it looks when they're doing their writing. Okay, so that brings me to the questions section of this. I wanted to give you guys an overview, and I'm happy to answer specific questions on telehealth if anyone has anything.
Thank you so much, Doctor, for your presentation on telehealth and for sharing some important tips for getting the most out of our upcoming telehealth visits. Thanks to everyone for submitting so many wonderful questions for today's webinar. Before we get started with the Q&A portion of today's talk, I just want to quickly acknowledge that we're unable to answer questions that were about an individual's health. The questions that we've selected for Dr. Sklerov to answer today will hopefully be applicable to many of you who are tuning in here. And please feel free to drop any questions that you might have in the chat box of the platform you're using. So let's get started. The first question that we have is, what genetics are involved in PSP and CBD, and how does MSA differ?
So that's a great question. We actually got several questions on genetics and these conditions. So For the most part, MSA, PSP, and CBD are not genetic. The vast majority of people do not have a known genetic predisposition. The vast majority of people do not have any family members who are affected and will not pass it down to their children. That being said, there have been a few instances in the literature, in all of the scientific literature, there's only been a handful of instances where more than one person in a family has either PSP or MSA. I am not aware of families with more than one CBD, but I may be corrected on that. What is more in these families with PSP and MSA, in the PSP families, there has not been a gene that's been identified that confers PSP to people in this family. In MSA, there of the approximately 6 families that have been described in the literature where more than one person has MSA, there were 2 families, Japanese families, that seemed to have it's a genetic variant in the CoQ2 gene that seems to confer an increased risk of MSA just in those 2 families. However, there have been genes that where there are families that have other types of neurodegenerative diseases where 1 or 2 of the family members will have PSP or MSA. For example, there are large families with a lot of Alzheimer's or frontotemporal dementia, and related conditions, where 1 or 2 of the family members may have, instead of frontotemporal dementia, may have PSP or may have SA. Actually, with MSA, we also see there's been families with Parkinson's where 1 family member may look more like MSA rather than Parkinson's disease. So for the PSP and CBD that we see in those families where a lot of people might have frontotemporal dementia or ALS, and then 1 or 2 family members may have instead PSP or CBD, the genes that are associated with that, those families tend to be the tau gene, the MAPT gene, specific mutations. There's also another gene called C9orf72, where family members may look like they have PSP or CBD or even MSA instead of the usual frontotemporal dementia and ALS that we would see in those families. There have been studies that have looked at large groups of people with MSA, PSP, and CBD to try to identify whether there are certain genes that are more likely to be mutated or certain variants that are more common in those conditions compared to people who don't have those conditions. And they have in PSP and CBD, there seems to be a slightly higher rate of certain haplotype or a certain flavor of the tau gene, MAPT gene, but it's a very slight, increased risk of having that gene among people who have PSP, CBD, or MSA. Yeah, I hope that answers the question. I'm happy to elaborate more if anyone has more specific questions.
It absolutely does, and I also want to mention that we've talked in our previous other sessions of Ask the Doctor quite a bit more with other neurologists as well about this particular question. So this is a question that we get very often, and we've handled it in a couple of different webinars. So for anybody that's interested in more information about that, you can go to CurePSP.org, and specifically to our other Ask the Doctor sessions where there have been different answers and kind of supporting evidence shared with answering that question. So thank you so much. Moving on. The next question is, besides a neurologist, and of course you spoke from your experience as a neurologist here today, what other allied healthcare professionals or therapists do you recommend pulling into a care team with somebody that's dealing with PSP, CBD, or MSA?
That is an excellent question. So for this, I'm actually going to group MSA a little bit differently. For the most part, there's a lot of overlap, but there may be a couple more specific specialties that we like to have for each. So for everybody, it is really important to have physical therapists, occupational therapists, and speech therapists who are familiar, at least familiar, with the PSP, CBD, and MSA conditions. Unfortunately, because these are relatively rare conditions, it is hard to find allied health professionals who are very well versed. But for the most part, what we've been finding is that those people who are really familiar with Parkinson's and have a good amount of training and background in Parkinson's have probably seen a good amount of PSP, MSA, and CBD, even if they didn't realize it. So to have on your team, on your care team, people from physical therapy, occupational therapy, and speech therapy, I think is pretty essential. It's very, very important. At UNC, I run a multidisciplinary clinic for MSA, PSP, and CBD. And what we found to be helpful is actually we also have a pelvic therapist. A pelvic therapist is a physical therapist who specializes in pelvic health. They deal with issues from urinary incontinence or urinary retention to bowel incontinence or constipation. They do deal a little bit with sexual dysfunction, and they do other urological and gynecological issues. So we've been finding them very helpful, particularly for our patients who have a lot of autonomic symptoms. Very helpful for constipation and can be very helpful for urinary symptoms as well. For the most part, I have noticed that because our patients with MSA tend to have more of the autonomic symptoms, we use the pelvic health a little bit more with MSA, but I have found it helpful with everyone who comes to our clinic. For PSP and CBD, neuropsychology can be very important. So having a neuropsychologist on the team is very helpful if that's available in your area, especially someone who is interested in PSP and CBD. And then finally, actually, psychiatry is also very important in the care of these conditions. We do see a lot of affective symptoms as well as behavioral symptoms that we often do ask for help from our psychiatry colleagues. So we do our best to find people who are at least familiar with these conditions, and most of them will have treated Parkinson's. For the most part, we have the most luck with geriatric psychiatrists. They seem to be more knowledgeable about which patients our patients may be more sensitive to and maybe wouldn't be our first line options for treatment.
Excellent. I also want to share with everybody that's tuning in today that CurePSP does have a document on our website that is specifically for allied healthcare professionals and specifically therapists. So for any occupational, physical, or speech therapists that you might be working with, you can head over to our website and download that if they need a little more specific information on treating these conditions.
Yeah, and I want to say, actually, Joanna, that's a really great point. We do use these materials, and our multidisciplinary clinic. Our therapists are trained in PSP, MSA, and CBD, but a lot of our patients don't live close enough to us to be getting their therapy with us. When we send them to other professionals, PT, OT, speech, pelvic, whoever in their community, we often will mail them the CurePSP pamphlets for PT, for OT, for speech therapy, with the referrals that we send, and people have been finding it very helpful.
That's beautiful to hear. And exactly, I mean, just having tools to advocate for yourself and make sure that you're getting the proper treatment is really important, especially with these rare diseases. Another question actually that you kind of touched on a little bit is the emotional behavior. And so the next question is, what changes in emotional behavior, particularly with respect to lack of empathy, are characteristic of these conditions? Is emotional behavior impacted more with a diagnosis of PSP, MSA, or CBD?
Good question. So it's been recognized for a very long time that even though we define MSA, PSP, and CBD as by their motor features, you know, the slowness, stiffness, falling, balance, you know, those symptoms. The reality is that these are diseases that have just as many, if not more, non-motor symptoms compared to the motor symptoms. And some of the most difficult to treat and most disabling in many ways symptoms of MSA, PSP, and CBD can become the emotional and the behavioral symptoms that people experience. Specifically in PSP, the apathy is we do see apathy in all three conditions, but in PSP and I would say even CBD, we do see more apathy, where people lose not only their enjoyment of things they used to enjoy, but they just stop caring really about things that are going on around them, or caring even show, or even sometimes it's not that they don't care. It can also just be that they're not able to show their emotions the same way that they were before. In PSP, apathy is quite common. The kind of other behavioral features that are very common in PSP would be impulsivity. So impulsivity means when something pops into your head, an idea, you act on it before really thinking, or often what I see in my clinic is you say to, someone decides they want to go grab something from across the room, and before really thinking about, okay, well, how do I do this? I get up slowly. I have to take my walker. They just kind of pop up and start walking, which can lead to a lot of falls. So that is something we definitely see a lot of in PSP. We also see that in CBD, but a little bit less prominent, I would say. Irritability is also quite common. It's a common behavioral feature of PSP in particular. And unfortunately, I was warn people that this irritability especially can be made worse by some of the medications that we use, particularly the Carbidopa, levodopa, or Sinemet, can make irritability worse. Other emotional or behavioral things that we might see in PSP, we can see depression, we can see anxiety, we can see even paranoia or even delusions, which is less common, I would say, but it can be seen. We also can see emotional lability, people very kind of laughing in one moment and then crying, at the drop of a hat, getting very sad. Sometimes it's really emotional lability, like they feel happy, they feel sad, but a lot they can also develop what's called pseudobulbar affect, which is kind of crying when they really don't feel very sad, or laughing when they don't really think something's that funny, excuse me. That pseudobulbar affect is actually something that we see a lot of in MSA as well.
Hmm.
I would say it's actually more common in MSA than in PSP or CBD. MSA, we also see relatively high levels of depression, more so than even in PSP or CBD. The levels of depression that we see in MSA are more than what we expect in the general public, even with the same amount of disability or chronic health concerns. In MSA, we can get some of the emotional lability as well as the pseudobulbar affect. We really rarely see the disinhibition and the or paranoia that we sometimes will see in PSP, but depression and even anxiety can be quite common.
Thank you so much for answering that question so thoroughly. The information about MSA is new to me. So thank you. Let's move on to a question that's specifically about PSP. So switching over a little bit here. We have a question that came in, I believe, through Facebook. What is the best way of managing aspiration for patients with advanced PSP?
So management of dysphagia and aspiration really go together. Dysphagia means difficulty swallowing or inability to swallow. And aspiration refers to when food or liquid or saliva go down the wrong tube, when you're really breathing in saliva or food, and it's getting into your lungs. And of course, the risk with breathing food or other material, non-air material, into your lungs is that you can choke. But even more commonly, people will get infections. They'll get aspiration pneumonias, and we know, doctors and actually health experts know, that the most common cause of death in neurodegenerative conditions, all of them, is infection, with lung infection, especially aspiration pneumonia, being right up there, really one of the most common causes of death. So we really do worry about this quite a bit. So it is usually advisable for people with PSP, MSA, and CBD to be getting fairly regular swallowing evaluations. This can be done with a speech therapist, and they do kind of what we call a bedside swallow evaluation, where they watch you eat or drink certain consistencies and see how you handle it. And then often I will also recommend objective swallow exams, which would be something like a modified barium swallow, which is like an X-ray. They have you drink something, and we use an X-ray to watch how it goes down, and we can see if it's getting into the lungs or if it's all going down the way it should. There's also a FEES, fiber optic endoscopic esophageal. I don't remember what the S stands for, but anyways, we put a little camera through the nose, and it kind of sits at the top here where we can see your vocal cords. You can see the throat, and then we have people eating drinks, and we can watch and see how well they're able to swallow, and if it's going in the right tube, wrong tube. And those will also really give us an idea. They can tell us if there's weakness in some of the muscles of swallowing, if the vocal cords are doing the right thing when they should be doing the right thing to protect the airway. And depending on what the issue is, we can recommend either exercises to strengthen muscles. We can recommend, sometimes our ear, nose, throat doctor who does our FEES will recommend some sort of intervention for vocal cords if they're not closing properly. But a lot of what happens after we do a swallow evaluation is therapy based. So speech therapy to work on the muscles, like I mentioned, but also to teach you about safe practices for swallowing to avoid aspiration. So they always will talk about positioning during eating, taking small bites, alternating a sip of water with a bite of food. And it's not uncommon that dysphagia or difficulty swallowing progresses with all three of these conditions, to the point where it is just not safe to eat or swallow at all under any circumstances. If people reach that point, the options are that you would talk to your doctor about. There is an option for a feeding tube that would be placed directly into the stomach from outside. And if it's determined that it's just not safe to take anything by mouth, then the idea would be that the person would stop taking anything by mouth, and everything would be given through the feeding tube. Now, we know that the feeding tube does not totally eliminate the risk of aspiration, but it definitely reduces it in those cases. But even before feeding tube, there's a lot that can be done in terms of altering the consistency of the food, consistency of the drinks, water, that can really help avoid aspiration. But there have been studies looking at whether or not carbidopa levodopa can help with aspiration. That does not seem to be clearly the case. So unfortunately, we don't really have a medication that helps.
Okay. Thank you so much for answering that question. And you segued really nicely into our next question, which is actually about carbidopa levodopa. And I'm wondering if you could talk a little bit about it. And somebody had asked, what happens if carbidopa levodopa is stopped suddenly?
Yeah. So carbidopa levodopa is a mouthful to say, right? But so levodopa is the active part of the medication. Levodopa is the precursor to dopamine, And dopamine is just a neurotransmitter that's produced actually everywhere in your body. It's not even just in your brain. And all parts of your body really love dopamine. They want to use it up. And that's why there's so many side effects from the medication. So the carbidopa, levodopa is a combination pill. The carbidopa is meant to basically prevent your body from being able to use up the dopamine until it gets to your brain. It just kind of saves it for the rest of your body. So carbidopa levodopa is really helpful in Parkinson's disease, because in Parkinson's disease, the main area of the brain that is experiencing neurodegeneration is the part of the brain that uses dopamine, that produces dopamine, excuse me. So in, it makes sense that if you're not producing dopamine, then giving dopamine would help. Now in PSP, MSA, and CBD, those parts of the brain, which is particularly, this is I'm talking about the substantia nigra part of the brain. That area is also affected in MSA, PSP, and CBD. However, there are other areas of the brain that are also affected that make it so that giving dopamine doesn't answer everything, doesn't encompass all of the problem. And in fact, actually, in all three conditions, the area of the brain that receives the dopamine often is also affected. So when you're giving dopamine in Parkinson's, the area receiving the dopamine usually is functioning quite well until very late stages of the disease, while in MSA, PSP, and CBD, that area that receives the dopamine is also affected. So just giving dopamine does not, have as robust of an effect. However, in my patients who have MSA, PSP, and CBD, we do find that the carbidopa levodopa, which we also call used to call Cinemet, can be helpful in certain ways. So in MSA, oftentimes we find that early on in the disease, the medication can be quite effective. Some people will even report a very robust effect. Usually that effect wears off over time. It becomes less robust. But oftentimes people may have some effect from the medication, well into the late stages of the disease. Unfortunately, in MSA, a lot of times people might have side effects, more side effects from the medication than people without MSA might have. Particularly, it can worsen orthostatic hypotension, so low blood pressure. Sometimes people can also have a reaction that is basically a dystonia or abnormal muscle contractions, particularly in the face or jaw. It can affect speech. It can affect ability to eat and chew. So we do have to watch out for those things. In PSP and CBD, in my, anecdotally, what I find really the medication can be helpful for is to reduce falls. So oftentimes people don't notice much of an effect of the medication when they take it, but they find, oh, wait a minute, I'm not falling as much as I was before I was on it. Otherwise, rarely people will say it helps, for example, if there is a tremor, it can help with that too. Now, the other part of the question, what happens if you stop carbidopa levodopa suddenly? It's actually very, very much not advisable to stop carbidopa levodopa suddenly. We find that people can have actually fatal reactions if it's removed suddenly. It also, of course, depends on how high the dose was before it was stopped. If it's at a low dose, stopping it suddenly probably won't cause any problems. But stopping it suddenly when it's at medium or high doses can cause, at the very least, a lot of discomfort, muscle aches, sweating, feeling trembly, feeling just very sick and unwell, very, very stiff. But it can be so severe that it could cause death. So I would never suggest stopping it suddenly.
Thank you so much. I want to take a few moments. We have time for 2 more questions. And being a part of the patient and care partner advocacy team here at CurePSP, I want to talk a little bit about the importance that you see in patients who are dealing with PSP, MSA, or CBD, working with a support group, getting involved with a support group, or getting involved with having a social worker on your care team. I know that at UNC you guys have an incredible multidisciplinary clinic, and I would love to hear, why you think that multidisciplinary clinic is so important and what kind of positive effects you've seen from people joining support groups.
So thank you. So going back to the question you asked me earlier about the care team, a social worker is such an important part of that for us, and I'm sure would be anywhere where you could get a social worker. We have a social worker at UNC who is specific to our movement disorders division. That's Jessica Schroer, and she's phenomenal. She's really wonderful. So she plays a lot. She wears a lot of hats, like plays a lot of roles on our team. And one of the roles that's very important to us is the role she plays in our multidisciplinary clinic. So I mentioned our multidisciplinary clinic. We have all these specialties that see the patient on the same day, and then afterwards, after all the patients have left, we have a meeting and we discuss each case and come up with a set of recommendations that combines all of our expertise. And really and one big piece of that evaluation actually is the social work evaluation. Jessica does a psychosocial assessment. So assessing basically, she does a lot of questions on affect, mood of the care of the patient as well as the care partner. Because we do look for, it's called caregiver burnout, but or caregiver burden, but it's really a very important and I think underrepresented issue in treating PSP, MSA, and CBD. So that's a big part of our evaluation. Also assessing, living conditions, social network and social circumstances is really key because, I'm sure some of you have experienced your doctor making recommendations that, just are not possible to do for whatever reason. Like during COVID, exercise, for example, is very difficult to do. If you can't go to the gym, if you can't go to your exercise classes, for example. So her role is really key. And another thing that Jessica does in our group is she does run our support groups, and we have a support group for MSA, one for PSP and CBD, and she does others for Parkinson's. And it's been really, we started the MSA support group about maybe a year and a half after I joined. The PSP and CBD support group had been going on before I came. And it really, from the feedback I've gotten from people is one of the reasons that I'm just so happy that we have this resource. These are rare conditions. It's a rare disease. It is not like Parkinson's disease. And so many people, when they learn of the diagnosis, or even before they know that they have this, but they've been diagnosed with Parkinson's, for example, they go to a Parkinson's support group and they don't feel like people are talking about them. They don't feel like they can really relate as well to what people are experiencing. And I've had so many people tell me, I've never met anyone with this disease. Am I the only one? Am I the only one experiencing this symptom and that symptom and going through this whole journey? And hooking people up into the support groups has given them another support system, another area where they can freely talk about what's going on and even get not only emotional support and understanding, but also they share tips, things, devices that they found or things that they found that work for whatever symptom or whatever mechanical issue is happening. So it really has been very important for a lot of our patients. Now going to a support group is very personal, which Joanna, I know you're more, you know more about this than I do, but it's a very personal decision. For some people, that support that they get from there, that almost affirmation of what's happening, and also, being able to talk to someone who really understands what you're going through is really critical. For other people, they get scared or it's uncomfortable to talk about these things, or see people in various stages of the disease, or having different symptoms than what they have, because it can be scary to see that sometimes for some people. So it's a very personal decision about whether or not you would like to go to support group. But from my experience, the majority of my patients do go to them and get a lot out of them.
That's fantastic. Thank you so much for talking about it and shedding some light on why you have a multidisciplinary clinic and the important people that make that engine run. I also want to shed some light on the fact that CurePSP does offer a number of virtual support groups for PSP, MSA, and CVD. And for many of you, this is no surprise. But for any of you that are new to the CurePSP community, please head over to our website. We have specifically, I know today we're spending a lot of time talking about MSA. We have a Care Partners of MSA Patients support group run by Tom Tate. We have a People with MSA support group run by Kathy Chapman. Just really fantastic volunteers that are committed to creating a space for people to connect. And we not only have groups for MSA, we have lots of other disease-specific and demographic-specific support groups. So thanks so much for talking about that, Dr. Sklerov. We have about 2 minutes left, and I'm going to ask a loaded question, so I'm just curious about your brief thoughts on any research into MSA that you've seen. I recognize that might be a lengthy question, but if there's anything that you can share that would be hopeful for our community, I'm sure we'd be interested in hearing it.
Sure. So there's actually, it's an exciting time for MSA. We have a lot of interesting ideas coming down the pipeline. One of the questions that we got online, which is kind of a very a big topic, was what is the pathomechanism of these diseases? And the reality is that there's a lot of overlap. They're very similar in how we think they come about, the pathology that we see. And there's different lines of thought. Like one of the popular beliefs now is that the PSP, CBD, and MSA have a very big neuroinflammatory component. So inflammation in the brain may be either causing or propagating this disease. So there's currently a couple studies using drugs that are meant to reduce inflammation in the brain that are being tested. There's also on the pipeline antibodies to alpha-synuclein. So alpha-synuclein is the pathologic protein, the protein that seems to be accumulating abnormally inside of neurons in people with in the brains of people with MSA. That is probably we think it's causing the degeneration that we're seeing. It may also just be a result of the degeneration we're seeing. We're not sure, but so that is a very exciting area. I would say there's vaccines, but there's also this antibody that's coming down the pipeline. Those are the two main areas that I think are well. There's also stem cell. Actually, there are some stem cell trials that are coming out of mostly Mayo Clinic that have had really promising results. They've actually been running those trials for close to a decade, I would say, and following people for a long time. And they're showing some pretty promising results. But those studies have been really small so far. They haven't opened them up to larger groups of people yet. So we'll see. But that is also an area that is very promising. I'm very excited to see what they come up with. And when they get to the next stage and start enrolling people, I will be absolutely trying to send my patients to get into those studies, actually all those studies. So sorry, I know we're short on time, so I didn't want to go into more detail, but there's a lot of stuff happening for MSA right now.
Which is so wonderful to hear, and thank you for a quick snapshot and for sharing some hopeful information with us. And thanks so much for your wonderful presentation on telehealth today. It's great to see you. Last saw each other, I got to meet you in person at our UNC CurePSP family conference. So Thanks so much for being here with us today. And thanks to everybody that is tuning in. We appreciate you sending in your questions and for engaging with us and for being here. Like all of our previous Ask the Doctor webinars, this video will be archived on our CurePSP TV YouTube channel and on our website in the next few days, so please keep your eyes peeled to further communication. We're so thankful to all of you for joining us this year during our Ask the Doctor sessions, which started in March, or actually maybe it was April with Dr. Golby, excuse me. We have had the pleasure of hosting some of the sharpest and most cutting edge and compassionate neurologists in this important field throughout the year. So please go and check out the rest of the recordings. As I mentioned, this was our 7th Ask the Doctor webinar. They feature doctors like Dr. Golby, Dr. Pantalia, and Dr. Scholes, in addition to so much more important content, including the videos from our caregiver conference and our family conference that took place virtually this year in November. Lastly, these webinars and events are only made available because of donations and because of viewers like you. So thank you so much for all that you've done to support CurePSP this year, and we wish you a happy new year, happy holiday season. Please stay safe, stay healthy, and we'll see you again soon. Thank you so much, Dr. Sklerov, for being here.
Thank you, Joanna. Thanks to everybody who's in the audience too.
Absolutely. We'll see you again soon. Thanks all.